All right, yes. So everyone, welcome to today's webinar. I'm Elizabeth Krupinski. I am the co-director of the Southwest Telehealth Resource Center. Next slide, please. I would like to extend a very special welcome to all of you who have joined today's webinar, especially those of you from Arizona and our Southwest region, as well as our colleagues in other states and other TRCs. Next slide. We've been doing this since about 2011. The Southwest Telehealth Resource Center has been around since then, and we partner with the Arizona Telemedicine Program to bring you nearing 200 different informative webinars in that time. Today's webinar is also being sponsored by the Arizona Department of Health Services. And this webinar and all of our webinars are recorded. You push that little button in the beginning to continue. And they have been archived, and this one will be too, and they will be available probably within about, well, Monday the latest. It is Friday, so give us a chance there. Next slide. As you join today's webinar, your microphone was muted. So please use the chat function of Zoom to ask any questions. We'll be watching this and monitoring it for questions afterwards. We will also capture it in case we don't get a chance to address all the questions. And then Carol will be able to email you answers once if there are any leftovers. Today's webinar is being recorded, as I said, and you will be able to access today's webinar and previous webinars on our website. Like I said, give us a little time to get this one up as it is approaching the weekend. The URL is listed on this slide and will be part of posted later on as we go into the chat. So it is my absolute pleasure today to introduce today's webinar, the ABCs of RPM, and your presenter, Carol Yarborough. We're pleased to have her back for another building webinar. It's a hot topic and people are very interested. Carol is a healthcare compliance and reimbursement specialist. She has a unique background in legal technology, revenue management, clinic management at both the state and federal level in terms of regulations. For the past 6 years, out of the 16 or so she's been in healthcare, she has actively contributed to various telehealth initiatives at UC Health, and she also works hands-on with professional fee and hospital-based fee professionals to implement billing strategies and provide real-time feedback to clinicians regarding the documentation and the staff with encounter guidance so they can get paid. She also trains CPT coding professionals at UC Medical Center to maximize EMR workflow with greater documentation and coding. So she's just like an absolute expert in this field, and we love having her here. And so without further ado, I'm handing it over to Carol.
Thank you for that very warm welcome, Elizabeth, and thanks, Chris and Chris for hosting me again. Yeah, I searched long and far and wide to find some free clip art to say for this ABC slide. But yeah, the ABCs of RPM, remote physiologic monitoring. So our agenda today, keeping with that ABC theme, is acclimatization, or otherwise known as a frog being placed in a pot of water that slowly warms up. That's how I'm kind of envisioning how we're all getting used to RPM. The water's just being heated slowly. B will be the basics, kind of going back to what we have in terms of access, remote patient monitoring for Arizona, and communication in terms of how we're getting updates on all of these different interpretations and things going on with the government. And of course, we'll have references in the questions to follow. I'm going to speak a little bit slower. I know I go kind of fast usually. Okay, so acclimatization. Did I say that right? Joel, straighten me out. Medicare fee-for-service, from which all guidance and knowledge flows. So I am going to say in 2018, we were all so thrilled with 99091, which was brought to us by the AMA And it was an evaluation and management code, since that's where it ended up in the CPT book. And it was for a qualified health provider. So this meant an MD or an NPP who can, an entity or a person or an entity that could bill an evaluation and management code only. So no staff, no allied health professionals. And the baseline of 30 minutes within a 30-day period of looking at patient-provided data. So, and of course, I always interpreted the time involved with data accession, which meant, you know, finding it in your EMR and typing in your password. That's not a good one. But, you know, finding the data, kind of reviewing how it looked sent in the various formats that a patient would give, especially back in 2018 while this was new. And I bring in this Nixon Gwilt article because we were really trying to nail down that this did involve communicating with patient and caregivers. That's part of that E&M kind of give and take you have. And it was the first code, and people were always like, well, is there a copay? Yeah, everything from Medicare fee-for-service does have that share of cost. And since it's non-face-to-face, CMS didn't want patients and beneficiaries to be surprised by, I don't know, the $5 bill or $10 bill they'd get for their share of cost for this CPT code that they weren't aware of. Well, I'm just giving you my data and you're reviewing it. Why do I have to pay a copay? Well, you obtain consent first, and then, you know, away we go, and you know why you're paying and what's happening. So that's why consent usually is initiated by CMS beneficiaries and for other insurance. So here's an example of, you know, from CPT Assistant, from a tried and true source. We have the clinical example of a fellow with diabetes with a home CGM. So it's not continuous, it's a GMD. And so they've been collecting that data themselves and then put it into their computer on a spreadsheet, and then they can either email it, transmit it, and the data are reviewed. So the physician or qualified health provider, which includes you know, nurse practitioner, allied health provider that can bill an E&M code, would review, interpret, and communicate back to that patient. 30 minutes. All right, I would like anyone, just to stimulate a little chat in the chat box, to enter a yes or no, whoever billed a 99091 in good faith, or even in, not in bad faith, but wow, did anybody ever manage to build this code? Let me see. Yeah, nope. Oh, that was an emphatic no from Andrea. No, not. Okay, fantastic. Oh, we're getting so many more no's. Not that I'm aware of. Yeah, I know. Sometimes providers can be sneaky and just slip that one by and put it on an old 1500. Okay. Yeah, not a very friendly code. Not a very friendly code. My sneaking suspicions, and others who are involved with ad nauseum discussions about RPM or this type of exercise, it's in the E&M section, digitally stored data and remote physiologic monitoring services, non-face-to-face E&M. The 30-minute threshold, the RVU when it was introduced was 1.66. Now it's down to 1.63. So, you know, roughly a 99213. Maybe you could have talked to the patient about their data, looked at it, and maybe you'd even incorporate that into your data points prior to the 2021 guidelines. and move that up to a level 4. I mean, you're spending that 30 minutes. So you may as well build a face-to-face encounter. May as well. So the year of 2019 brought us the gift of the remote physiologic monitoring codes. There were 3. 99453, which we know and love as the education training. 99454, the provision of the device, which, read this carefully, for practice expense related to supplies for daily recordings or programmed alert transmissions. That's clear, right? We didn't spend the last 2 years talking about that definition. And this code should not be reported for monitoring of less than 16 days. Okay, well, so those 2 codes seem kind of okay, you know, but these are still in the E&M section of the code book. These have to be done by a QHP in 2019. So it's called a monitoring service. So these are the definitions I yanked from CPT code, from the AMA, patent and copyright disclosure being made right now. So it's digitally stored data and remote physiologic monitoring. So this is all just monitoring again. So these are the codes that are there under E&M. Set up in patient ed, so you bill it once per treatment, regardless of how much equipment you're doling out. You got a scale, you got a blood pressure monitor, you have a pulse ox, maybe a digital thermometer. You get one bill or one CPT code. And then the monthly, after the 16 days of recordation and transmission and receipt of data, you get to bill that 99454 once every 30 days. 99091, still there, still helping us out. Definition was up there. 99473, and you're like, wait a minute, where's 99457? We're not there yet. We're talking about the monitoring services and where they're grouped in the CPT book. So the 99473 is self-measured blood pressure, bill once per device, ever. So that's like the 99453. You bill it once per device or per treatment initiation. And then the 99474 is, again, this is kind of a crazy code, twice daily over a 30-day period with a minimum of 12 readings before you could actually bill that out. Okay, so minimum of 12 readings meant maybe it's like every other day or every third day, but certainly 12 within a 30-day period, twice a day. So maybe, okay, I'm going to diss my brother, but I know he's not on this webinar. He would take his blood pressure before he would drink his espresso every morning. So his blood pressure seemed cool. But after his coffee, stratospheric. So maybe his provider would say, Jim, I want you to take it before you drink your coffee and after your coffee. There's no escaping fate. You need to calm down. Okay, so this is a great chart. The parameters for reporting in CPT codes. You got your 99457, we're getting there, versus the 99091. I know it's like we're jumping around a little bit, but this is a little segue. Wow, the 99091 doesn't need a medical device defined by FDA. Maybe I can use my watch, hold my finger on my wrist. Doesn't need a prescription. What is coincidental is reported once per 30 days. Only one could be reported with chronic care management. And remember, 99091 used to be bundled. It was a status B code because that was part of chronic care management. It was pulled out to give us the management of one chronic condition. I don't know, it still seems like a cool code to me. Maybe the blush of first RPM, I just still love it. Anyway, no one else did though. Maybe reported with TCM, and we'll talk about those at a later time if folks are interested, either of those code sets, or behavioral health integration services. 99091 stands alone, like the cheese. So the FDA defined device. So it does say it's a medical device supplied to a patient as part of RPM services. Supplied to a patient gives you that sense like, okay, the practice expense of that 99454, I have to give you, I'm the provider, I'm the clinic, it's my practice expense. I am supplying that to you as part of that. And it must be a medical device defined by section 201H, basically. And what my good friend Amanda, my new bestie, that we met over RPM, you may find you're finding more friends over discussion of RPM than you thought humanly possible. She saw, hey, a tongue depressor is a medical device defined under this section. So great. It doesn't have to be approved. It's just something you use in a medical setting. And I think as a provider, consistent with its data reporting. That's a little important. So it all fits in with 99453, 454, 5758, not the 99091. Everyone's following along with this so clearly. I just know it. All right, 2020. It was a new year. Let's say this brought hope into our pre-pandemic souls about RPM. It brought about changes in supervision, and it brought in another add-on code. So RPM can be furnished incident to under general supervision, and 99458 came in to identify additional time in conjunction with that 99457. Usually incident to services have to be under direct supervision, and Noridian just gave a very fine presentation this past week on incident to. You can go to their website. I believe I posted that on the reference page, where you can find the recording and the slide deck. You won't get your CEU for it. You're not getting a CEU for this, but I mean, it's a really great presentation. And they did mention incident to does have exceptions to bypass direct supervision. The reason that you could bypass it for certain things like homebound people and, geographically, low population areas where a doctor is not going to, or a doctor, an MD or an NP are not going to be right there in the home with the RN that is there in the home, taking care of that patient. So that could be then done under general supervision. So nobody's recalling any kind of exception given to RPM. Am I right? Haha, but also in that year, it was redesignated as a care management service. Care management services can be under general supervision of the physician or QHP, qualified by education, training, licensure, regulation, when they are provided incident to the services of a physician. I know your minds are blown. Mine was too. As I reread all of these regulations, things that seem mysterious and panic inducing in the past makes sense now. Whatever you know, I was very confused up until I put this deck together yesterday. No. So it's still in the evaluation and management code section, but now it's under care management. So that's where I've highlighted the word management away from that monitoring on that prior slide. So remote physiological monitoring, treatment monitoring services, 453, 454, 99091, 73, and 74. So this is now management services, which allows the general supervision. That's crafty. That was genius, I think. My machine's heating up here. Thanks, Zoom. Anyway, oops. There is a typo. That is a 99458 for each additional. I will fix that before we distribute the slides. Billing. Okay, the mysteries. Oh, mysteries of RPM. At last I found you. This isn't telehealth according to CMS. So no modifiers go on these codes. Place of service is where the service was provided. I do want to thank someone in Texas who submitted some pre-discussion questions. So which place of service is used when a hospitalist, I'm sorry, a hospitalist, I like that term a lot better, at the hospital is overseeing the program? It's where the service was provided. If you did an inpatient training of a 99453, you supplied the device to the patient, it does say practice expense, this will probably not be billed on a 1500. This would go onto the UB04 for the hospital, and it probably more than likely not would get rolled into the DRG cost report. So your trainer, your doler outer is going to bill that 99. Oh God, I'm spacing on the codes. Just 99453. And then for the recurring monthly, if the hospitalist is going to be the one reviewing that monthly data, if they're following that patient and they're on all the time, or that service is going to be monitoring this patient, then it would be place of service 21 inpatient hospital. If the RPM is going to transfer to the clinic setting, then you've got your 11 or 19, 22, pike. So that's a great question. I never really even, I mean, of course, we were handing out pulse oxes and billing within 2 days. I should take a poll of who actually billed that. All right, so we're going to go to the basics. Basics. So we're going to talk about Arizona Medicaid, otherwise affectionately known as Access. So they're a little bit different. Checking my time. I'm speaking slowly today. I'm happy about that. Okay. So Arizona Medicaid, remote patient monitoring, different nomenclature. I often thought that, you know, we all have problems with telehealth definitions. Am I not right? What's telehealth? Is it telemedicine? Is telemedicine under telehealth? Like, so nomenclature wise, I'm not dissing Arizona, but it is remote patient monitoring. So just know that if you're reading physiologic in your CPT book, and then you're like, but wait, Arizona said patient monitoring, is that something different? No, because they are using the same codes, but this is the name of their program. So it is located under telehealth. Now remember, Medicare said it wasn't telehealth, so you don't need any modifier. But for Arizona, and I know other Medicaid programs, it is telehealth, being overseen by the telehealth programs in those states. So the codes do require the GQ, which is for asynchronous, whereas our telehealth billing requires 95 for synchronous, used to be GT. And then this is taken directly from this telehealth initiative URL. The location of the access member at the time of service is being furnished via telehealth, or so that is where your place of service is going to come from, is where the patient is. Patient's at home, then it's place of service 12. And then confirming the coverage during COVID-19, you've got this great FAQ site on their website. A lot of great information on there. So I did want to pull some of these paragraphs from the telehealth manual itself. This is a great definition. Remote patient monitoring. You can read it. It's a member in one location, to a provider in a different location. I don't think it's saying that the patient's got to be in one location all the time. It's just saying we're separated by distance and time. So you've got the patient here, or the access member here, and you got your provider over here. So we're providing improved chronic disease management, care-related support. Such monitoring may be either synchronous or asynchronous. So RPM, that would be synchronous. We can all think about it, but I'm thinking if you're in an RPM program that is going to give real-time alerts, all of a sudden somebody's 5 pounds heavier than they should be. Even monitoring overnight even. I mean, these are different types of RPM that can be provided. You can create a program as the definitions stand now, the way it's going to work for your practice. You're going to be either 24-hour, you're going to be business hours, you're going to be 12, whatever. I think. I'll let any of the attorneys online with us to straighten us out in the chat. So I've gained 5 pounds. An RN calls the nurse practitioner. The nurse practitioner calls me and says, hey, you gained 5 pounds from yesterday. Did you take your diuretic for your heart failure or whatever? I know I forgot. I'll take it now. So that's great. I mean, that kind of feedback is great. Or if it's, it's not so life-threatening, they could call the next day. But if you have somebody who's like, the brink of fluid overload all the time, or, it might be great to have real-time feedback. Anyway, I digress. So, so they also give this caveat in this manual call out as well. So they're saying synchronous real-time telemedicine and RPM doesn't replace provider's choice. Like Access is not going to say, oh, you're only going to give this population RPM. Doesn't replace the member's choice. Like provider's not going to say, you're going to get RPM. I'm never going to see you again. No, member gets to say, you know what? I'd rather come in every day and have you take my vitals because I live next door. And these are Access covered services that are medically necessary and cost effective. So there's your policy URL. I just love the Access site, actually. It's really easy to find stuff. So telehealth, again, so now we go to the provider manual. There's a fee-for-service provider manual. We're talking about telehealth and RPM all over the place now because it's so relevant. Telehealth, here's its definition. This is what these services are in Arizona, according to the Access fee-for-service manual. And RPM, transmanaged, so that's the same definition. Just in 2 places. All right, dual coverage. So what do I do when the patient's got Medicare and they only want telemedicine services with a place of service 02 or with RPM 21? So we're not thinking pandemic right now. We're thinking, pre and post. Let's think post, like post. So it's for Medi-Medi, you're going to comply with Medicare guidelines. You're going to designate it with a service being provided as telehealth with O2. So the telehealth coverage is going to vary. So you get back that Medicare claim in first. You get the explanation of benefits back, any kind of money, and then you submit it to Access. And I think, now here's the billing manual, and there are so many, I dabble in billing, I dabble. Maybe it's going to go over to Access with Place of Service 21. What about other Medicaid programs? Well, my friend in Texas asked a question about different codes. I had no idea this even existed. And so I'm doubly and triply thrilled that a pre-webinar question had been asked, 3 questions. The term home telemonitoring is used in its policy for remote physiologic monitoring. So it's home telemonitoring, and it's got a different code, S9110. And you need prior authorization. And each time additional home telemonitoring is needed, you need additional authorizations. Here are the URLs to help. And then with that particular thing in Texas. And then, of course, shout out to Center for Connected Health Policy and their 2020 all-inclusive 50 state plus DC report on who has what kind of coverage. You can start with the CCHP documentation, go to your state. They list all the relevant 1134. They list all of the precise code sections. Now, there are no URLs because we know URLs break all the time. Here, have some URLs. But they give you the code sections. So just copy and paste those code sections into the Google and ask the Google, take me to this code section. And it'll take you right there. And you click on it, you can read what you need to read. It's a great guide. So my friend in Texas, here is this. So S9110, but wait, there are like all those other codes. How do I even handle that in Texas? There's just one code. Well, welcome to the land of modifiers. So what would be a 99453? Yes, that is a landline ringing in the background, Luddite. U1 is for the 99453. And then it's got different variations of monitoring days, which is kind of, I think it's cool. Monthly home, so these are the 99453 codes, but at different time intervals. I see nothing for the providers. Probably Bill 99457. Aren't you glad I said probably? That's really a definitive answer for you, Ms. Texas. But we can delve further into that. Or anyone on this webinar can go to that CCHP manual, go to the Texas URL. How about a little love for the presenter? Just communication, right? It's all back and forth. We're all talking about RPM all the time. I mean, literally, we are, because we love it. So, you know, the physician fee schedule that came out for 2021 had all sorts of gems for us. Not only were we introduced to the 2021 evaluation and management codes during the PHE, not a bad thing since it got everyone kind of used to billing by MDM or time. I must say that total time and MDM also conflicted with prolonged time. goodness, badness. And then for this final rule or the draft, it said, no, it wasn't the final rule. It said that 20 minutes of time associated with each of these codes, 457 and 458, was all interactive communication. What we loved about these codes is that you're going to do all that stuff that you could do under 99091. Okay, I'm whining. So yeah, you want to review the data. What? I'm going to review all the data on my own time. My car mechanic's going to like look at my brakes and sort of repair them almost on their own time and then only bill me for the brakes. I don't think so. We need some cogitation and reward here. So they did agree and they came out with a final clarification. CMS, January 16th. Like we agree. It should include care management services. I mean, it's under the care management codes. Yeah. So it's total time. And it's not the only activity included in that total time, because we have total time codes now for evaluation and management under the 2021 guidelines. So why not just roll all this together? No, it's a bad idea. We won't do that. Not after all the work and discussion we've had. So anyway, I digress again. So, okay. I did entitle this Back to the Future, but I want to say, the future really is going towards quality outcomes, right? Someday, we heard 2023 at one point, maybe 2025. This is moving us there. So we're going back to the beginning. There was a CPT panel meeting in October 2020. This is on its website. I'm not breaking any confidentiality. It does say any of the discussion that occurred during that meeting is confidential, but this document is available to everyone at this URL. They are going to revise remote physiologic and clinical data monitoring. So they're only revising 99091. So maybe this is transitional. It's effective next January, possibly, hopefully. It says right here, another typo, effective date. They're going to move this code to the medicine section. High fives all around, right? Where it should have been in the first place. So yeah. And we're going to get introductory guidelines to provide guidance for appropriate reporting of the new codes. Now look, there's 1, 2, 3, 4, 5. There are 5 codes that are going to make up this one. Initial setup education, device supply, and treatment. So what if I have my own device? Then you don't get the device supply and treatment management code. I'm hoping they break it out into 2. So you get your education with number 1. I give you the device, you got number 2. You have your own device, use number 3, then 4 and 5 is your qualified non-physician QNPP, qualified non-physician provider use of these codes, which is part of that 20 minutes that you can now accumulate following incident 2 guidelines. If you have a direct contractual relationship with that allied health provider or with the clinical staff. So we're going to get introductory guidelines. This is great. Like, I like that they left it under the care management codes or moved. They had it under evaluation and management under digital. Then they moved it to care management because this was unbundled from chronic care management. But now it's going to get its own medicine section where it, yeah, we're definitely traveling in the right direction. I just hope that if someone already has an eye health thing, or they have their cardio or their whatever, their own Bluetooth scale. I'm actually motioning to mine right now. It's not Bluetooth. That we shouldn't incur greater costs just because we're going to get paid for it. People have their own stuff and it calibrates and it gives you a baseline. Why not? All right, so here are the resources. Arizona jurisdiction JF. Here's your education and training events. You can find prior events on here as well. I highly recommend the Incident 2 RPM article where Nate goes into great detail talking about the general supervision. Even though I gave you that additional information about when general supervision typically applies and when direct doesn't. So for his next article, maybe you could go into that a little bit more. I winked, did you see that? And then there is a new Mick Jagger and Dave Grohl song. And here's the URL for it. Jagger he actually sings Zoom. I thought that was cool because what are we other than just being Zoom heads? But they're actually singing about more the light is growing brighter at the end of our PHE tunnel. So it's 11:43. I would love to answer so many questions to be unbelievable. And
all right, here we go.
Woo!
Yeah, we are ready. We got a lot of questions. Are you ready?
Wait,
all right.
Okay.
Does
Giants cup. Go Giants.
Yeah, have a drink of coffee because here we go. Does 99454 cover cellular data fees associated with the integrated device?
No.
Okay. Does 99457/8 billing require the patient to be using an integrated device?
Okay, this is hotly debated. Yes, because it is part of that set. If you're not using an integrated device, use 99091 or use that time that you're spending looking at the data from a non-integrated device as non-face-to-face time if you're doing it on the same day that you're doing an E&M visit.
Gotcha. How many times per month can the 99458 be billed? I'm presuming for the same patient.
Once.
Okay. What should the quote from and to service dates be for each RPM code?
Well, this sounds lawyerly. There are different time parameters. One of them says a calendar month and the other one says every 30 days. I can't remember which ones. We'll go back and read the definitions, right? But, you know, the from to date should be, you hand the patient the device. And if you only want to have a device handing out day on the first of the month, so your billers don't go crazy, you can do that. Like, hey, it's device day. No, it should be the day the patient was supplied the device and then the end of that 30-day period after 16 days have passed. I think I've answered that.
Yeah, no, I think so. That was good.
Okay.
You said at one point that RPM, according to CMS, is not telehealth. Could you expand on that? What do they mean by that?
Yeah, well, it is not on the telehealth CPT code list. That was mysteriously just updated for March 30th and uploaded on April 7th. If everybody wants to go race there and check out what was added. It's not on that list. So anything not on that list is not telehealth.
Okay.
That's the
straightforward.
easiest answer I can get you. Yep.
That makes sense. Overall, and then if you know for Arizona specifically, is there a difference between synchronous versus asynchronous RPM?
I think in that example I tried to give about synchronous RPM is someone's constantly monitoring your data and you're getting feedback, biofeedback constantly. That would be tiring. I bet you it's all just asynchronous.
Okay.
Yeah.
I think I know the answer to this one, but would uploading of patient physiological photos for monitoring quality for RPM reimbursement, for example, post-surgical wounds and burns, is that considered remote patient monitoring? I don't think so. That's more
No,
store and forward, just to consult
that would be,
follow-up.
yeah. Or, even if you're sending, say you had a surgery done and then you wanted a dermatologist to look at the wound, that would fall under an e-visit. So that's your 99421 through 99423 code series, where you go into patient portal, upload your stuff. You agree that you're going to pay for it because consent has to be obtained. Provider reviews, gives the opinion back.
Yeah.
Not RPM.
That's what I figured.
Oh, good.
If done as an outpatient, not an inpatient,
Okay.
RPM program overseen by the hospitalist, would that be POS 12?
Yeah. Yeah. So I'm thinking in this question, this is a clarification of the question from Texas. The hospitalist does have to have privileges in their bag of tricks, I believe, that would allow them to bill outpatient stuff, right? Any physicians on here, or med staff office people, if I don't have privileges or even if I'm not billed into the EMR as an outpatient provider, I'm not going to even have access to that part of, say, scheduling, or, you're going to see the data, but you have to be able to have the privileges to see a patient on an outpatient setting. I think that's negligible. Yeah, that would work. And if the hospitalist is ill and just can't be on their feet recovering, and let's use everybody all the time. I'm bored. I need to see patients. Here, watch some data, Mr. Hospitalist and Mrs. Hospitalist. So they can sit at home and monitor and write RPM reports and bill POS 12.
All right, I don't really see that happening with so many board physicians, but that's okay. RPM does not require real time, correct?
Correct.
Correct, exactly.
Non-face-to-face. Oh, but it does require interactive communication. So does that mean you send an email and you get a read receipt? Or do you have to call that patient? So you know what? I think it does. Interactive communication. What does that really mean? I'm hoping the new definitions maybe help out on that. But interactive is kind of what Elizabeth and I are doing right now.
Yeah. Just texting back and forth is maybe not so much.
Yeah.
You previously mentioned that you posted a link for a webinar on Incident 2. Did that ever get in the chat?
It wasn't in the chat, but you can go in the, here we go. Let me go back here. References or resources. Education training for Noridian JF. They did do it for JF and JE this past week. So there should be a deck and a recording available to everybody. If you go into the Noridian site, you can download that stuff.
Here's a philosophical one for you. Okay, it's not a yes or no. What are your thoughts on RPM reimbursement becoming disease specific?
Huh.
Do you have any thought? Have you thought about that before? It's an interesting question.
Well, a little. I mean, 99091 is supposed to manage a chronic condition. One. And to qualify for chronic care management, you needed two or more, right? So chronic care management was, you had COPD and CHF and
Diabetes
or whatever. 99091 was to allow you to pick one of those three and manage it. Now, RPM, I really think, opinion, disclaimer, that it's per episode of care and what you're doing, like what's happening now. Like, conditions can be transient. They don't have to be chronic. So I want to monitor that COVID patient after 2 days with a pulse ox and get paid for it. And voila, they do pay. So I kind of think it's not going to be disease specific.
Okay, great answer. Are there any unique differences for critical access hospitals?
Any unique differences? Yes, cannot bill for it. So,
okay, that's pretty unique. That's an important difference.
Yeah, I think one of our next sessions should be on critical access and rural health clinics associated with a CHC.
All right, well, you just volunteered.
Yeah, because it's confusing for everybody, and there are per diem rates that are allowed. I do know that during the PHE, certain things are being paid. But as it stands now, RPMs are not payable to an FQ or an RHC.
Okay,
and so any kind of hospital associated with that, I wouldn't.
Yeah.
But if it's COVID, I would bill it. If you're monitoring that patient after 2 days, in those FAQs, take a look at those FAQs we referenced in another webinar.
Okay, it's another one. You're booked.
Well, there's a COVID-19 FAQ that has all that stuff in there. COVID-19 CMS FAQ. It's cool. About 130 pages long.
Okay, so that'll put you to sleep.
Yeah.
Any suggestions on how to get CMS to eliminate the 16-day restriction? There's so many clinical scenarios where fewer days are needed. So how do we change the government? Any thoughts there?
You can write to the AMA CPT editorial panel. You can write directly to the CMS folks that are in charge of RPM that you can see on the Federal Register. And she writes you back. That's an amazing thing. And I'm spacing on her name right now, but if you go to the Federal Register for this year, do Medicare Physician Fee Schedule Federal Register, you'll get the final notice and then the whole listing of who's in charge of what program. You can start emailing her daily, perhaps. No, I wouldn't. No, don't do that. But yeah, certainly, writing your legislators and getting involved with policy groups like CCHP. We have a policy group that meets on today. Stuff like that. So if you have any questions about getting involved with that, just shoot me an email.
Cool, great. We only have a few more. We may actually get through these today. We got 4 more minutes, but does providing a patient with a Bluetooth enabled device, i.e. blood pressure monitor that pairs to his or her own phone and an RPM app qualify as a connected device?
Yes.
That was easy. Let's see. Is RPM POS physician or patient location?
Okay, so in Arizona, it says where the member is located. For CMS, it's going to be where the provider is located, because it's where the service is being performed. So if you have a patient coming in to get their device and get training, that's happening on site. And then any management reporting and interactive communication that takes place is going to be where that distant site provider is located. We've gone back and forth on these, POS 12 versus clinic, but this is definitely where the provider is located in this instance.
Perfect, thank you. Is it possible for a medical student to act in RPM services?
No.
No, unfortunately.
Yeah.
Do you, I'm not sure.
I mean, they could, you just wouldn't get paid. Okay.
Yeah, minor detail.
Yeah.
Do you confusion having a patient being monitored concurrently with RPM and CCM?
It can be done concurrently, per that little chart that was on from the CPT assistant. They would have to be for different diseases though. So
Okay.
you would have your, yeah.
Excellent. Okay, I got two more quick questions. The new
Okay.
codes you described near the end relating to RTM, is there guidance on the criteria? There's 5 new codes, or put another way, do we have guidance about whether the review of independently performed PT exercises would satisfy these new codes?
No, I don't know.
Okay, we'll see if we can get some clarity on that one. And the last one, any insight regarding RPM becoming reimbursable for FQHCs? Or we just kind of discussed that.
Stay tuned.
Yeah, stay tuned. Okay, one final one that just came in. Follow up on the connected device question. Hypothetical. In the event that a patient can't get their Bluetooth connection to work and is manually reporting their readings into the app, does that suddenly not become billable?
Yes.
Okay.
There's human error involved.
Ah, gotcha.
And there's like, you know, numbers get fudged.
Yeah, no, that is true, especially
Yeah.
with things like blood pressure and weight and all that other good stuff.
Yeah.
All right, if you could go to the next slide. We had questions. Go to the next. There we go. I am pleased to let you know that Carol is going to be back with us on May 10th at 12 p.m. Pacific time for our monthly virtual office hours. We'll have an open discussion on telehealth billing, and you can find the link to register on our homepage. And hopefully we'll bring her back to her own suggested webinar on CHCs and FQHCs. Next slide.
And please submit questions ahead of time.
Yes, please do.
So I don't have
this presentation has been brought to you by the Arizona Department of Health Services, the Arizona Telemedicine Program, and the Southwest Telehealth Resource Centers. For future webinars and events, please visit our website. And last slide. As always, we super value your opinion, so please take a few minutes to fill out an online survey. As you exit, you will be taken directly to the short survey, or the link is right there. We thank you, and we certainly thank Carol very, very, very much for that wonderful presentation. I think we all learned a lot. Your expertise is very much appreciated.
My pleasure.
Thank you, everyone.
And thank you for attending today.